This is Selma Schimmel at the San Antonio Breast Cancer Symposium, and joining me now is Dr. Stefan Gluck, Sylvester Professor in the Department of Medicine, Assistant Director, Sylvester Comprehensive Cancer Center, Associate Chief in the Division of Hematology Oncology at the University of Miami Health System.
Thank you, Selma. It's a pleasure to be here.
I thought we could spend a few minutes just sort of getting your take, your feelings about this meeting, and in particular, obviously, we talk over and over again about personalized medicine. We want to make it more than a buzzword.
I couldn't agree more with you, Selma. Personalized medicine is a buzzword, but it's much more than this. It looks into much more than just the cancer that we removed from the breast of the patient when it's breast cancer and other cancers, and do some stains and look what it is. Personalized medicine actually includes, first of all, the person, so the patient. She may have completely different ideas about outcome and about how to reach it than myself as a physician. And through the practice of many decades now of medicine, each and every person is different. And then you have the tumor, which now we understand more and more, and every day, and including this meeting here, we have heard so much about different, not only molecular subtypes, different mutations, but even some of these targets that we believe we know, such as HER2 or estrogen receptor, they have mutations themselves. These small pieces of genes in the cancer cell, they may be different than in a different patient. It can be as little as 2% of difference, but it makes actually difference between outcome and choice of drug. Having said it means we need not only to take the tissue and look in the microscope, we need to do basically much, much more. And therefore, we need tissue, not only the first time, but even when a patient unfortunately has a recurrence or a second cancer on the other side. What it means is this cancer may or may not be the same. It can be actually completely different. And occasionally, we have two different cancers in the same breast. And finally, to make it even more complex, the same cancer, as little as it might be, can have heterogeneity, which means portions of the cancers are estrogen positive and others are negative. And those that are positive for estrogen may have a mutation on it, and the estrogen pathway, and that's another buzzword we should learn now, the pathway is functional or it may not be functional. Why does tamoxifen, as an example, work in 50% of all cases? Because the pathway may not be the dominant driving force for this particular cancer in half of the cases. So it comes all together now, at least in principle, as we understand. And to understand more better, we need actually these tissues. We need large banks or repositories, they call it, with clinical outcome that will 5 or 10 years later give us if or when the cancer had such and such feature, the outcome was so and so. And only this way we can do the most modern markers that are changing every year, twice or three times, keep up to date. Finally, and it's even a little bit sad on the one side, because these are the women who will suffer most if they have a recurrence inside the body, so develop metastatic disease. We also need to do biopsies. This cancer may be completely different than it was a year or 2 or 3 years ago. So that's the key issue, that women and physicians understand a biopsy is not just diagnosis and metastasis or a cancer, it's much, much more. And then you can tailor around the diagnosis with all the molecular typing that we are trying to do now, and the wishes of the patient, what they call personalized medicine.
What are your frustrations in being able to obtain adequate tissue?
Actually, it's quite interesting. Patients are very understanding if I explain them why we need a biopsy. It's more the regulatory person or people, it's the IRBs, which is why do you need 2 biopsies? Why do you need 3 biopsies on your study?
IRB, Investigational Review Board.
Right, so the ethics committee, you can call it also. So people who are helping to protect what they call the human subjects on study. The human subject is the patient on the study. So the wording is kind of funny or not adequate, but it is what it is. And we sometimes have to wait weeks, if not months, before we get permission to do these things. And then, of course, you have the advocates or the people or the group that say, well, it is an information which may lead to something which at the end of the day may not be good for the patient. So are they protected? But I think we have good laws that protect the patient already. We don't need additional roadblocks. So if we continue to to understand how important it is and adhere to current regulatory components of the process, we should be fine.
And in speaking to advocates, they're quite passionate about this issue, and advocates would like to help facilitate the process, and we believe that the majority of cancer patients, if asked, would be more than happy to share tissue. Right. And again, you've echoed what everyone has said, which is that it's the regulatory aspect that is the greater challenge, not getting women and patients in general to participate in sharing tissue.
There's another small aspect to explain to a patient why she needs, or he needs a biopsy, or why we need it to make the best treatment decision for the patient, takes a few more extra minutes in a consultation process. And as we are, interestingly enough, I hear it across the world, busier and busier, and we have less and less time for a patient, we have more patients, the diagnoses are more complex, treatment are more complex, they're living, which is excellent, much longer than they lived 5 or 10 years ago, but it is a big burden on the physician or the nurse who has to explain all this. So it's another aspect, which is not unsurmountable, but it is an aspect.
I thank you.
Thank you very much.
I'm glad we had these few minutes with you. Dr. Stefan Gluck, Sylvester Professor, Department of Medicine, Associate Director of the Sylvester Comprehensive Cancer Center, Associate Chief, the Division of Hematology Oncology at the University of Miami Health System.
Thanks, Selma.